And good morning, everyone. Thank you so much for choosing to spend some time with me this morning. I'm happy to see names of friends and colleagues near and far. I'm Julie, and my background is in physician compliance and reimbursement for a variety of provider types. I'm passionate about helping providers optimize their revenue in a compliant manner, and I'm excited to share some valuable information over the next hour or so. So the word audit carries a lot of negativity and makes a lot of us groan and roll our eyes, right? Myself included. The perception is that they add more work for little value. But I think everyone on the call this morning knows that the value of conducting coding audits, whether they're internal or external, is certainly there. Some of it is a matter of leadership buy-in, organization culture, things like that. So we're going to talk through all of those situations. Aside from compliance and reducing risk, this is also the best way to protect your bottom line, which at the end of the day is what a lot of us have a vested interest in. I understand that if you or your organization have never been in trouble, so to speak, before, it's hard to justify the time and cost of coding audits. So I'm going to talk about why they're beneficial, but also how to easily fit them into your normal workflow and how to get the most out of them, whether they're performed internally or externally. We're going to start with a compliance overview to level set this morning. Because we have attendees from a variety of organizations and types of facilities, there's a couple of points that I want to cover before we get into the weeds. There's a couple distinctions to make when talking about audits, and the first is the difference between coding and billing. A coding audit is going to focus on documentation and coding, which organically may identify some billing issues, but it's not specifically going to focus on billing processes. That's a different type of audit that would include like payment reconciliation and validation and things of that sort. Coding happens prior to billing, and depending on your organization, the coding may be done by providers, coders, charge entry staff, or another type of staff member. One of the questions we received in advance of the webinar this morning is related to the credentials of auditors, which I'll talk about later in the presentation. But I do want to make the point that the coders in your organization should all be certified. Now, if you're in a hospital or an ambulatory surgery center, then you'll likely look for coders with AHIMA coding credentials, whereas medical groups and physician practices tend to look more for AAPC certified coders, but that's not set in stone. In the following slides, I'm going to talk about how this affects your coding audits, the difference between coding and billing. These processes both start at patient registration, whether you're in an office where the patient calls to make an appointment in advance, or if you're in a hospital where a patient could be admitted directly or is admitted through the ER. And it all ends when the account has a zero balance. Coding is reliant on the clinical documentation within the medical record, and billing is the application of the codes onto the claim forms for reimbursement. Of course, these two tasks share a common goal, but they're more different than they appear on the surface, which we're going to explore in the next couple of slides. So this is just an example of how coding and billing rules may differ. So if a procedure, such as a steroid injection, is performed bilaterally, the modifier requirements may vary by payer. And if they're not correct on the claim, payment could be delayed. So it's up to your organization to determine who interprets the payer guidelines. You may prefer that the coders assign modifiers based on payer guidelines, which certainly carries an inherent risk to rely on your coders to know all of the rules, and it could also impact their productivity. Of course, depending on your organization, so many EMRs are now sophisticated enough to have rules built in by payer for appropriate modifier and diagnosis code assignment. They can also look at bundling issues, some medical necessity things and things like that. It's great because it reduces the reliance of humans to memorize rules or slow down and refer to notes to determine what to do as part of their process. And anytime you have a human touching a point in a process, there's always a little bit more room for error because we're human and we miss things. So this is an example where the actual codes may change based on payer requirements. Since 2010, keeping up with which payers allow consultation codes and which don't is headache-inducing. But you can see on the prior slide, the difference was really just in the modifier application to show the bilateral procedure. On this slide, it's showing how the codes may differ. I could make the point that on the prior slide with the modifier application, if you don't have an EMR that can apply modifiers based on payer rules and what was coded or billed, you'll want your billing team to be responsible for that. Now, if the codes are going to be different based on the payer, you might want your coders to do that. is just something to take into consideration. Every organization is different, and I'm just giving you some food for thought when you're determining how these processes will work best for you. Another complexity added to the audit process is the difference between facility and professional coding. So if you're in a hospital, then you'll have your facility claim that has ICD-10 PCS, which are the procedure codes, and ICD-10 CM, which are the diagnosis codes. And reimbursement is reliant on accurate capture of these codes to determine the severity of each patient or the acuity. Also in a hospital, you may have employed providers who require separate professional billing. Because facility and professional have two different sets of guidelines, these tests are typically separated. It's not the easiest thing to keep in mind, two sets of guidelines when coding the same services. One of the most glaring differences between the two is that for facility coding, all clinical documentation can be considered for coding purposes. For professional coding, only provider documentation can be used, and this gets incredibly complex as each note has to be able to stand alone, and there's myriad rules to keep in mind, such as teaching physician guidelines for residents, shared services with APPs. There's just a lot that goes into it. Alternatively, if a provider sees patients in a hospital and they're not employed by the organization, then the coding is likely done by their billing company or their practice staff. But a commonality here, anyone who has ever coded before or worked in health information management, whether it's on the professional or facility side, knows the golden rule. If it wasn't documented, it wasn't done. That's what we always keep in mind for coding. Now, if you do make the decision to hire an external auditor, this gets especially tricky for services such as observation, ED, and outpatient surgeries that have both facility and professional components. You'll likely have a couple auditing teams who are going to be working on the same claims. I'm going to talk a little bit about types of audits, which is going to lead into a conversation about compliance plans as well. So internal audits are the ones that are performed by your organization staff. And one of the benefits to internal audits is that your staff is aware of your internal processes and policies that may affect your documentation, coding, and billing. Of course, this is also the downside, as if there are bad habits, they won't be easily identified as they would be by someone who is outside the organization. If you see them day in and day out, you're less likely to recognize it as an error or a potential issue. Another thing to keep in mind is that coding guidelines change as frequently as quarterly, sometimes even more frequently as they did in 2020. And frankly, it's impossible to keep up with them. I know that a lot of compliance auditing departments are a department of one, and it can be a struggle if you have 10 people trying to keep up with all of the guideline changes. So with this, if your organization wasn't aware of a guideline change, it reduces the likelihood that you're able to catch that in an internal audit. The best times to do an internal audit are with the implementation of a new software, whether it's like a drag and dictation system or computer assisted coding, a EMR or practice management system, some software like that, or if you have a process change or when there's coding guideline changes. On the professional side in 2023, if that is part of your world, you likely know that a lot of the guidelines are changing for inpatient professional services. So very early on in 2023, you should be looking at what your providers are coding to make sure that they are correctly applying the new guidelines to their documentation, and also make sure that the coders are applying the guidelines correctly as well. So here's something about internal audits that we don't often like to say out loud, but most of the time, we just want to check them off the to-do list. Just get them done. It's something that we have to do. Let's just get it over with. So I'm going to be super transparent with you here. When I was working at a hospital and I was a coding supervisor and I was responsible for the monthly audits of the coders in my department, I just wanted to get them over with. And frankly, I was new in a leadership role. I think I was 21 years old, and all the coders had a lot more experience than me. And I didn't want confrontation. Let's be real. I didn't want the confrontation. Not only that, but it's really important to know that my mom, who was a coder and is now retired, worked contingent in our department. I had to audit my mother. I want to know in the chat if anyone else has had to do that. But needless to say, I wasn't the best at making audits meaningful at that time in my young career. And I have regrets, but I have learned and grown since then. And I know I'm not the only one. I'm sorry if you feel seen right now, but it's important to be realistic and know that you're not alone. That's why we're having this conversation today. I mentioned some of these points already, so I won't spend a ton of time on them, but Both internal and external audits will protect the bottom line of your organization. Also, it's your best defense mechanism to defend your organization from a compliance perspective as well. It's football season. I am a football fan. If you're not, just bear with me for 8 seconds while I explain that auditing as part of your compliance plan is like an offensive line. They're going to protect the physicians in your organization and frankly, you as well in your compliance department or whatever role you hold within finance, reimbursement, health information management, revenue integrity, whatever it is. Unfortunately, one of the things that we've noticed that doesn't always feel great for us is that sometimes the providers and leaders in your organizations just want validation of what you're saying, what you within your organization are already saying, but for whatever reason, they want to hear it from someone outside your organization. It gives them an additional level of comfort by hearing someone else say the same thing that the coders and compliance professionals within their organizations are saying. So that's a benefit, as hard as it is to know that. And an important plug to put in here is that if you suspect something is wrong, or even if you don't, but you know it's a possibility, you can put your external audits under attorney-client privilege. This protects your organization should an issue be identified and is later brought forward via a payer or government audit. From an auditor's perspective, it's helpful to know that the organization we're working with is being cognizant of potential issues. And in reality, we don't mind if any audit is put under attorney-client privilege just because you never know what's going to happen. It can be your annual, quarterly, monthly monitoring, whatever it is, or a targeted audit. It's always beneficial to have it under attorney-client privilege if that works for you. And that can be an attorney within your organization or outside of your organization. My recommendation is that your external audit supplement your internal auditing. This helps to avoid that fox guarding the hen house scenario. I'll talk a little bit more about the benefits of using external auditors later on in the presentation. So this is where you're going to start seeing a theme within my presentation when we talk about types of external audits. So there's scary and not so scary audits. When it's voluntary, it's great. I refer to voluntary audits as just for fun. I say this because you're just keeping an eye on things. And in this scenario, you just want to make sure everything is in order. These are our favorite ones because we're focusing on prevention and maintenance, helping you to avoid potential issues. So involuntary audits are typically done as a result of data mining by a payer or their designee. Blue Cross frequently hires someone else to do their data mining for them. And they've identified something that they want to take a closer look at. Now, as external auditors, we get pulled into these because they require a lot of time and attention, which isn't always possible for internal staff. It also just requires a level of expertise and detail that if you have really seasoned compliance people within your organization who have been there for a long time, they just naturally would not have the same level of awareness to the external factors that others do. This is also a benefit where our experience comes in because we go through this every day with our clients and we have specific strategies for handling payer and government audits. So we're able to put our prior experience with payers and government agencies to use for you. So now I'm going to move on to compliance plans to tie this together. So going back to the voluntary and non-voluntary definitions, there are voluntary compliance plans, which are typically developed by your organization. Hopefully they follow what the OIG recommends. You can see the elements on this slide. They have published guidance for different provider types. If you go to their website, you'll be able to find it easily and it'll take you to the Federal Register in which it was published. But it includes things like the development of policies and procedures, the designation of a chief compliance officer, establishment of a training program. You know, the other elements are listed on this slide for you. Compliance plans are lengthy and they can also be really difficult to maintain and implement. This is something that you can certainly delegate to an external company as well, but if you dedicate your time and resources into developing a compliance plan that's tailored to your organization up front, it's easy to implement and educate on an ongoing basis, as opposed to having an outdated plan or a canned plan that may include items that don't apply to you. If your organization doesn't currently have a compliance plan, I would highly recommend that you research some of the reputable companies that just sell a compliance plan and they'll tailor it for you because they're generally something that's pretty reasonably priced and they're going to essentially get it ready for you and your organization, your specialty, your number of providers, the services you provide, things like that. And again, it's making sure that it works for you, that it's tailored to what you're providing, that's going to make it easy for you to implement and maintain. Because if you're using either one that's too robust, that was maybe like one of your friends at another organization gave it to you, or you just purchased it out of the box and downloaded it from a website, of course, it's going to be really hard to maintain those on an ongoing basis because it's not meant for your organization specifically. So you're noticing a theme here that our preference is to keep everything voluntary. The time spent upfront in defending your organization with compliance plans and internal audits pays off in volumes to avoid the time and costs associated with involuntary audits. So of course, when you're doing voluntary audits, whether they're internal or external, you get to control the process. You also get to remain proactive and have the benefit of staying ahead of issues. When it becomes involuntary, it's naturally more stressful, and it's harder to see the big picture when you're so focused in that situation. When you're working with, especially a government audit, whether it's the OIG or the DOJ, it's very intense and intimidating, and it can be really difficult to be able to defend your organization in a productive and meaningful way. Involuntary compliance plans are implemented by the OIG, which is the Office of the Inspector General. And I have both IA and CIA listed here, although going forward, I'll likely only say CIA. That stands for Corporate Integrity Agreement. IA is Integrity Agreement. Integrity agreements are for solo practitioners or small practices, and corporate integrity agreements are for larger organizations and corporations. So let's go into a little bit more detail on that. So an entity agrees to a corporate integrity agreement obligations in exchange for the Office of the Inspector General to agree that it will not seek to exclude the entity from participation in Medicare, Medicaid, or other federal programs. So these come about, it could be like a whistleblower key tom type situation, which is always a really difficult and challenging scenario. Or it could be, again, like one of those payer audits. And we know that if, say you get an audit from Medicare, there's nothing that prevents them from also calling other payers, such as Medicaid plans or other commercial plans in your area, to alert them of what errors they found in your audit. So these are all the ways that the OIG can be alerted to take a look at an organization. And the corporate integrity agreements don't just involve coding and billing, although a lot of them do. I am quite sure just about every day we're reading about more organizations and providers that are put on corporate integrity agreements or integrity agreements. The hospital supply companies or device supply companies are definitely under scrutiny right now. And the other thing is, in 2020, there was certainly a lull in auditing by government agencies, but we know it has picked up tenfold since what it was in 2019. They are not only continuing all of their regular audits now, but telehealth, of course, is being put under intense scrutiny. So these are all things that we're expecting to see in the future come out from the OIG. But back to corporate integrity agreements. They have common elements, but each one is tailored to address the specific facts of the case and may incorporate elements of a pre-existing compliance program. So once an organization enters into an integrity agreement or CIA, they're required to hire an independent review organization or an IRO within a certain amount of time. And this is something that we do for a lot of our clients, unfortunately. They're typically 3 to 5 years. Currently, what we've seen for integrity agreements for the individual providers, they're 3 years with quarterly audits, and our corporate integrity agreements have been annual audits for 5 years. The 3-year agreements generally tend to have a smaller sample size requirement for each quarter, and the 5-year agreements that have annual audits have a larger sample size, but also a requirement based on the accuracy rate. So if you fall below a certain accuracy rate while you're on a corporate integrity agreement, then additional audits are needed. And one of the reasons that I want to point this out, this in and of itself, of course, is scary enough, and I don't need to keep harping on this, but independent review organizations are expensive. And if you don't meet that minimum quality threshold, then you're paying for more audits. And all of this is being said to entice you to do regular audits on your own. One of the things that we're asked about, though, as an IRO is that if an organization performs well, can the CIA end early? So here's the thing with that. The OIG doesn't usually terminate a corporate integrity agreement early. There would have to be an incredibly extenuating circumstance outside of audit results for that to happen, because the successful completion of the integrity agreement is just one of the requirements and is an expectation. It's not a basis for early termination. So the only exception, shouldn't say the only exception, but the most common exception we see is when a healthcare organization stops participating in federal healthcare programs, and then they can get out of their corporate integrity agreement. So if there's a closure, sale, bankruptcy, something like that. Other than that, there would have to be some type of significant finding after the fact for it to be eliminated early. Now, all of you on the call today, you can go to the OIG's website and look at every single organization who's currently on an IA or CIA. It's a little bit interesting to scroll through every once in a while. There's a lot of large organizations on there that you would recognize, like eClinicalWorks, which is an EMR vendor, Cardinal Health, which is a supplier, CVS, we all know CVS. They're all on corporate integrity agreements right now. In 2021, just something that's interesting, the OIG entered into 30 new integrity agreements. So 15 were IAs and 15 were CIAs. So I think that there's this misnomer that the larger organizations are under more scrutiny, which may or may not be true. That's a bit subjective. But the fact that half of those agreements were IAs, like, they're definitely finding a reason to look at those smaller shops that fly under the radar, so to speak. So that's one thing to keep in mind that surprised me a little bit, is just knowing that so many of the agreements have been integrity agreements for those smaller organizations. And I do want to take just a moment to talk about the False Claims Act here too. So this act provides that any person who knowingly submits false claims to the government is liable for double the government's damages plus a penalty for each claim. And this applies to both fraud and abuse, which is intentional, or I'm sorry, fraud, which is intentional, and abuse, which is unintentional. It doesn't necessarily matter if you know that it's happening or not. You know, if you knew that it was happening, there's obviously certain criminal charges, but the civil penalties are the same regardless. And claiming that a physician didn't know the rules or didn't understand the rules, that doesn't actually matter to the government, right? But they're not going to take a lack of knowledge or understanding, or frankly, even ignorance. It's not going to protect them from the penalties. And currently, under the False Claims Act, the penalties are $11,000 to $23,000 per claim, which is insane. If they look at 100 and then want to extrapolate it across your entire patient population, oh my goodness, I am going to stop being so threatening in just a minute. Not yet. In 2021 alone, though, the government collected $5.6 billion in settlements and judgments from civil claims involving fraud and abuse against the government, which is, that number is just mind-numbing to me. So a strategy for your organization to consider. The reason that I'm saying all of these things is to not only encourage you to monitor the OIG work plan quarterly, but monitor the corporate integrity agreements on the OIG website regularly, because you better believe that if the OIG successfully enters into an agreement with an organization, they're going to scope out similar organizations for similar issues. And both payers and the government are in the business of paying as little as possible, both upfront and through audit processes. And I do just want to reiterate, I do understand that everything I just said was probably just like a little bit threatening and terrifying, and it's reality. And it can all be easily avoided with a strong audit and compliance process. So let's keep talking about how we can avoid that. So, steps to performing an audit. The first thing that you're going to do is define your audit's purpose. One of the things you're going to consider is it going to be prospective or retrospective? So retrospective is the most common because it doesn't hold up your revenue and it allows a review of the entire claim that's submitted to the payer. There's value to prospective audits, there's value to that, but there's also value to prospective audits as it allows you to catch errors before they make it to the payer. As we reviewed earlier, changes may be made in billing, which wouldn't be caught in a prospective review. And a tip that I would like to share with all of you If you're looking for an external auditor to do prospective audits for you, make sure that you include a turnaround time in your contract with them so that they can be held accountable. You don't want to have an external auditing company that's taking 30 to 35 days to do a pre-bill audit. So when you're determining your sample size and your time period, again, go back to your purpose. If this is a targeted audit due to an identified issue, you're going to want to do a statistically valid sample that's determined using a software such as RATstats. We always use RATstats. We have to use them for IAs and CIAs, but because it's the government's accepted software, it's what we use no matter what type of statistically valid sample we're doing. Now, the reason that you want it to be statistically valid is that if you do have to do an extrapolation, it's an accurate extrapolation. If you're doing a baseline coding audit, though, say on a new service or provider, my recommendation is always to start with 1 day's worth of charts. So this doesn't mean to only select charts from one calendar date, though. What I mean is if a provider typically sees like 25 patients in a day, select 25 patients from a 1 or 2 week time period. You don't need to overdo it on that initial baseline sample because your sample is going to give you a good enough indicator as to whether or not certain services need a closer look. You're going to look at your results and say, if you have physicians in an inpatient setting, say that their high-level initial days were all lowered and their critical care codes didn't have time documented, but all their subsequent days were fine. You don't need to look at the subsequent days again this year, but you are going to want to look at the initial days and the critical care codes because that's where the issues were identified. So what I mean is you don't need 30 of every code type. You're going to know if it's an issue just with a sample size, and then take a closer look from there so that you're using your time effectively. And also when you're selecting your sample for a voluntary like baseline type audit, be strategic. You don't want 50% to be mid-level office visits. Intentionally go grab those higher risk services. We're going to talk a little bit about this in a couple of slides too, but just the general culture of your audit process, whether it's an internal or external audit, is that it's not punitive, it's educational. We can't say that enough. As much as especially coders feel attacked when they're audited, the whole purpose of it is to make sure that everyone is supported and educated and doing their job correctly. And if you've heard me speak before, this is naturally where I'm going to put in my reminder that both over and under coding carry risk. A lot of my providers tell me or show me that billing a higher number of low-level services, so like they want all their office visits at 99213 is what I'm saying, all their subsequent days at 99232. They say that's going to keep them out of trouble. Well, again, if you've heard me speak before, you've heard me say this, but it's not true because undercoding is seen as a way to entice patients to your facility, which is a stark violation. And we all know the government loves stark violations just as much as they do False Claims Act allegations. So that's why accurate coding is what's most important. So once you've gotten to this point, you get to the point of the audit, which is assessing documentation and coding accuracy. This need to keep the purpose of your audit in mind. Are you auditing the coders or the providers? Because the perspective and feedback varies based on your audience. If you're auditing providers, your feedback and education is going to be based on documentation more so than coding. I do understand that a lot of providers do their own coding, but what you're going to really be focusing on with them is their documentation. Now with coders, you're obviously looking at the code assignment, and there's not a lot they can do to change the documentation aside from sending queries. What your intent is to decipher the documentation into the appropriate codes and helping them to get through those gray areas because we all know that coding guidelines are mostly gray. Now, if you have a billing company involved, that adds another layer of complexity, but don't leave them out of the audit process. So now we get to the essence of audits. You need to use the data that you accumulate to your advantage. Make sure that you're continually monitoring results by provider, specialty, location, whatever makes sense for you. You'll want to know as soon as possible if there's improvement based on prior findings or if there's a new trend or change. This is why you do continual audits. You don't want to do one, look at your accuracy results, do one a year later, and look at the accuracy results again. You want to look at them over a period of time and make sure that those troublesome areas are improving. And if they're not, you're going to root cause and troubleshoot and then do process improvement to determine how you can improve it. This is also the time, if you're doing professional services, to monitor the E&M bell curves and compare them to whatever benchmarking data you choose to use. But it's critical to track your results against external standards and best practices because, again, living within your vacuum of your organization, which is especially common in larger organizations, is actually one of the biggest downfalls. The fun part is presenting and educating. It's natural to consider the feedback given to those responsible for what was audited, the providers, coders, billers, et cetera. Like that's what everyone does. That's the most important part. However, a transparent presentation of this information is also critical for your leadership team within your organization. Using the findings, you'll want to update your monitoring accordingly. And we're going to talk a little bit more about tracking KPIs in just a couple of slides. So then, once you finish the first 5 steps, as the shampoo bottles say, lather, rinse, repeat if necessary. But in our case, it's always necessary. But in all seriousness, this is where the magic happens. This goes back to what I said about avoiding it just being another check on your to-do list. We all love checking things off our to-do list. We all add things to our to-do list just so we can check them off. But when you truly prioritize this as part of your planning culture, it becomes easy, natural, and engaging. So let's keep talking about that. The frequency needed is dependent on your organization's need, of course. If you're a large multi-specialty teaching and facility and trauma center, you should be auditing constantly. You should be looking at everything constantly. I tell our clients, you're non-compliant 100% of the time. It doesn't matter how big you are. There's no way to be 100% compliant in every service 100% of the time. If you're a one-doc shop, your auditing will likely take place a little less frequently, but it still carries the same weight. So the graphic on this slide is the result of an MGMA stat poll from 2020. So what I found interesting is that the results are mostly even among quarterly, annually, and at least monthly. Annually is what I see most commonly in the work that I do, but I love to see clients that are doing their own audits more frequently in between what we do. Like I said, the external audits should just really be a supplement to what you're doing internally. When you're doing your internal audits, one thing to keep an eye out for is the most common causes of improper billing. So these are lack of documentation. This accounts for, I think it's about 64% of Medicare improper payments, just pure lack of documentation, however they choose to define it for each encounter. But followed shortly after that is no documentation at all, then lack of medical necessity and incorrect coding. And while we're here, because I just mentioned medical necessity, I do just want to talk about that for a moment because organizations perceive the auditing of medical necessity different. When I talked about the corporate integrity agreements and integrity agreements, one of the reasons that they get more pricey is because they always include a medical necessity audit, which has to be done by a clinician. So when you have an external audit done, I strongly recommend that you include medical necessity done by a clinician. Coders may determine medical necessity to a point using LCDs and NCDs, but outside of that, coders, regardless of their level of education, within their role are not able to assess or determine medical necessity. Coders are incredibly brilliant, and they know when something is off, but they don't carry the education and weight needed to give that advice on medical necessity that a nurse or a physician can. So when it comes to fraud, upcoding and billing for unnecessary services and services not provided, appointments patients did not keep, those are the most common acts that have been identified. And then after that is incorrect coding. My apologies. I did get on a soapbox a little bit about medical necessity, so that rounded out the most common causes of improper billing found in audits. So let's talk about what you're going to do with your audits now that you've had them done. There are several organizations that provide benchmarking data, such as MGMA, HFMA for purchase, and then there's private companies that publish data as well. CMS publishes some bell curve data, somewhat infrequently, but it also has value. The important thing is really just making sure that you're comparing yourself to others. I just said this a couple minutes ago. Make sure that you're out there comparing yourself to others so that you're not operating in your vacuum of your own organization where it's easy to lose track of what really needs to be focused on. So when you're looking at the results of your audit, you want to align the goals of the audit with your organization strategy. So for many of you, I'm sure that a key focus for you is revenue. So you're going to want to leverage these audits to identify opportunities. So for example, if you're looking to determine if coding is adversely impacting your case mix index, look at a focus sample of records of DRGs without CCs or MCCs and see if any of those were missed. Now, if growth is your goal, you're going to want to keep an eye on new services and providers that you're adding. Most audits have key metrics that are measured, such as like diagnosis and procedure coding accuracy, modifier accuracy. If it's a facility audit, POC and POA and discharge assignment, etc. But what else is going to be helpful for your organization? Make sure that it's tailored to you. Maybe tracking RVUs for your providers is going to be beneficial if they're paid salary plus RVUs, things like that. So one thing, if you take one thing away from this slide, what I want you to know is that audits are going to be tedious and they're going to feel counterproductive if they're not in line with your organization's goals and strategies. So that's why I'm saying your audit doesn't have to be a one-size-fits-all strategy or deliverable. And this is true whether you're doing it internally or externally. Your external coding audit firm should be able to tailor everything that they do to you and your organization. And make sure when you are working with an external vendor that they know what your goals and strategy and objectives are so that they can help support you in that. That is really why all of these audit firms exist, because we want to support you in being the most successful organizations that you can. None of us want to hurt an organization in any way. So one plug, as we talk about education, one plug that I want to add here is that when you're using an external vendor for coding audits, be sure that you share your internal guidelines with your auditor prior to starting the audit. So a challenge that we frequently face, this really attributes to the third bullet here about rebuttals, is that we will do a kickoff call, we'll ask for internal policies. 90% of the time we hear that they don't have any internal policies. And then we send the report out and we find out that there were internal policies or there's internal interpretations that we didn't know about. An example of that is something like a strict definition of prescription drug management or a more lenient query process on the facility side. There's certainly value to wanting to have an audit performed blind so that you'll strictly receive best practice recommendations from your firm. But if at the time of audit submission, your coding staff mentions internal policies, it results in angst for the coders because, they feel as though they're being told they're doing something wrong when they weren't because they're following internal policy. And then it's rework for your auditors, which is also costly. So we're always going to incorporate rebuttals into our audit process. But I'll just remind you to make sure that you're sharing your internal processes and policies. And if you do truly want like blind recommendations, then the rebuttal process is probably going to look a little bit different because it's not going to take internal practices into consideration. And I did mention a little bit ago, but education is intended to be collaborative and used as a medium to identify solutions rather than to harp on problems. And this is true whether it's an internal or external audit. Like I mentioned, when I was doing audits as a new supervisor, I didn't want confrontation and I probably didn't call out things that I should have. But the same is true for an external vendor. If you have an external auditor who is being aggressive or isn't engaging in conversation with more of that I'm right, you're wrong type attitude, that's not the right person for you. Your auditors need to be collaborative with you and support you and your teams in being as compliant and productive as you can be. And again, I'm going to talk about this a little bit more too, but one of the advantages is that we have this broader perspective outside of your organization that we're bringing with us to help you. And then this is essentially the culmination of everything that I've talked about today. Again, doing an audit just to check it off your list is never going to be meaningful or productive. If you're going to dedicate the time and money to doing them, make sure that they're doing the heavy lifting for you. So you're going to want to follow up on all the issues identified. So like I said, if you look at critical care services and identify an issue, you're not going to wait a year to look at 10 more critical care services. You're going to look at 5 next week, 5 the next month, and make sure that you're tracking the results, that you're seeing a continuous improvement. And when you do this, this is where you're going to be able to pinpoint where the problem is. Is it a specific provider? Is it the EMR? Is it a workflow or a process? It's that tracking that's going to allow you to determine how to fix it. And then monitoring the OIG work plan, I mentioned monitoring the corporate integrity agreements just to see what they're looking at. The work plan, of course, I think they update it quarterly now. And it's always going to have things such as modifier 59 on it, telehealth was on it and now is in a more substantial way. So just make sure that you're keeping an eye on that. If you don't know what else to audit what's in the OIG work plan. And then being consistent. Again, this is the same theme. If you just do an audit, then forget about it for a year, no one's going to try to make any improvement, especially when we're talking about providers who we all know they didn't go to school for administrative purposes or to learn how to document and code. They just want to help people. This is why we need to continually help them and support them in doing the best that they can. And I'll add one more point here on the professional side that I hear a lot of coders say things like, I don't look good in orange, I won't look good in stripes, things like that, with the implication that they're responsible for the coding and billing. Even if you have an external coding company, if you have an external billing company, the physician signs the bottom of every claim form and is ultimately responsible. So make sure that you're supporting your providers as much as you can. So why have external audits? A lot of you probably have internal compliance staff that has the capacity to do external audits. Us as vendors, we know what payers are auditing throughout the industry, and we can draw on our success with other clients. When I go through, say, a Medicare audit with chief complaints, that just strengthens my ability to support all of our clients in what Medicare is looking for chief complaints. Same with documenting time for Medicaid. We provide a lot of really good insight on those types of things because we've been through it with the payers. But a bigger benefit that I mentioned is our feedback on your internal processes. We can help you with tweaking templates or adjusting EMR workflows to ease administrative burden, and that helps your providers and staff, and it improves not only accuracy, but also your reimbursement. And I'll reiterate that only external auditors can help to identify bad habits that have developed, which is especially common at larger organizations. For example, I am familiar with an organization that in their emergency department, they bill a pulse ox on every single patient. Well, a pulse ox is protocol, so you can't bill for it. But here's the thing, when your coders have been there for 5, 10, 15, 20 years, and that's all they know, that's all they've ever done, it's not as easy for them to identify that it's a problem. So that's why even if it's just once a year, we have clients once every other year who just have us come in and make sure that those bad habits aren't poking their heads up and causing problems. And then the other benefit that there is to using external auditors is that we have access to more specialty specific professionals. So if cardiology is one of your bigger specialties or neurology is one of your headaches, and yeah, neurology being a headache, that's a great example. We have access to experts who can help with all of those specialties. And that also helps to support your organization because a lot of times, even in the larger organization, say that you have cardiology specific coders, they're, again, just operating within what they know. It helps to have another cardiology auditor come in once a year and just help them out with a couple of charts to make sure that they're still on track doing everything appropriately. So before I open it up to questions, I want to let you know that a link to the survey for this webinar is being posted in the chat. I would absolutely love it if you took the time to fill out the survey so that I know what I can do different in the future. And if there are topics that you would like to hear me or someone else at Rybar talk about, make sure to add those too. Now, we did get another question in advance of the webinar that I want to talk about real quick. So please start putting your questions in the chat and I will get to those. But one of the questions that we received is, are there specific licenses or training that coders have to be an auditor? So no, not that are required, depending on the organization, but in general, no. Most of the best auditors I've worked with have coding credentials, such as an RHIT or a CPC. There are auditor credentials available, though, which do show that you have taken the initiative to add that extra layer of expertise to your skill set. So one of those would be AAPC has a CPMA, which is a Certified Professional Medical Auditor, and HCCA has a certificate in healthcare compliance, something along that line is CHC as well. And there are others, but really your experience is key. What makes you a good auditor is a variety of experience at a variety of organizations. along with some other skill sets. We look for people who are good at educating and have that collaborative approach with providers and coders. And I do see that there's some questions in the chat, but I want to point out, if you're shy, like I obviously am, feel free to shoot me an email or give me a call with your questions. My contact information is on the last slide. So I will take a look at the chat to start answering questions. A lot of stuff going on in this chat. Okay, if a practice uses a billing company, should they be included in audits? So yeah, I did start to allude to this. Definitely, if you're using a billing company, make sure that you include them in your audits, because they obviously are carrying a lot of responsibility for your organization. And one of the things I'll point out is that your organization can still be put on an integrity agreement, disqualified from Medicare or any federal program because of what your billing company is doing. Because again, your providers and your organization are ultimately responsible for all of the billing, no matter who's doing it. So it is critical to make sure that you're keeping an eye on what your billing company is doing. I would also include them on the same cadence. It wouldn't be a less frequent audit, because again, you're putting a lot of trust in that company and you want to make sure that they're doing the best job possible for you. How do you engage physicians in reviewing audit results? That's an excellent question, because physicians are busy. And like I already mentioned, they will tell all of us that they did not go to school for this. And we hear them. They are busy doing really important things every day. And documentation and coding is not necessarily on the forefront of their mind. So I go with a physician's personality. The couple slides that I had that talk about like the penalties associated with false claims and the penalties related to underbilling. Some physicians respond to that because then they realize, oh, wait, it's not as easy or as clean cut as it is, as they initially thought that it was, or as their colleagues may tell them that it is, things like that. So I make sure, so that's one, is to use a scare tactic. The other, again, I can't stress enough, is to be collaborative with them. They're like coders in the sense that you're really just trying to help support them do the best that they can every day. And that when you're sharing this feedback with them, you're just helping them to perform the best that they can. And if they're on a contract that pays based on RVUs, you can tie the money to it. Look, if you improve your documentation in this sense, or you're already documenting, but your codes are too low, make sure that they understand what the financial impact is to them and their organization, because not all providers respond to compliance. We know this. So those are a couple of tactics that I use, but also being really brief. That's unfortunately my habit of speaking too fast, is that I have talked to physicians for my entire career, and I know I have to say what I need to say fast because I only have their attention for a few minutes. So making sure what you have to say as clearly as you can. When I am speaking to a compliance professional, I generally tend to add a lot more color commentary to what I'm saying than when I'm speaking to a physician, because they're not going to give me as much time. What educational path do you recommend for a biller who would like to move into coding? That's a great question. I love it when billers want to move into coding. The first slide, coders don't always understand what billers do. Billers don't always understand what coders do. As a biller, you already have a really strong skill set in understanding a lot of the medical record, the revenue cycle processes, things like that. Is that front end piece that you need to add on, interpreting the documentation. So I would recommend seeking out an organization like a HEMA or AAPC that has educational opportunities, and choose a credential that's right for you. And that's one of the best ways to get your foot in the door as a coder. I would recommend, if you are more interested, or if your career path naturally is leading you more toward the professional side or physician practices, look at AAPC. If you're on the hospital or ambulatory surgery side, actually, let me say, if you're on the hospital side, look at a HEMA. They have the certified coding specialist and the RHIA and RHIT, which both require degrees. And then in an ASC, you can probably go for either, though I'd look at the certified outpatient coder from AAPC for that one. What criteria should we use to evaluate potential audit vendors? So what I would recommend that you look for as an audit vendor, I mean, of course, price, right? Of course, look at price. But check to see what their audit process is. Do they use an audit software? What's the output from that? They should be able to give you a sample deliverable so you can see what their report looks like. Are you just going to get a line-by-line detail report? Will it be divided by provider? Are you going to get a detailed narrative? Is education included, or do you pay extra for education? Do you want the education? Do you want it to be group or individual education? All of these things, and your audit vendor should be able to work with you. Like I said, if you need to put in a specific turnaround, that should be in there. When it comes to their pricing, Julie Hardy's personal recommendation is not to pay hourly for audits. That is not the most economical. I would do a per encounter or per chart rate. So I do have other friends who do the same work that we do that charge hourly, and it works great as well. But when you have a per encounter rate, that typically includes everything with the reporting, research, anything that comes up. So then you know what to expect. Whereas the hourly, if you do it, make sure that you cap the number of hours or get a range of hours so that you know. And then from there, definitely get references. References are a little bit funny. It's not too dissimilar from getting references when you're hiring someone. You know, of course, we're not going to give you the name of someone that didn't like us, but you can target your questions so that you can get the answers you want. Like, what was their turnaround time? Did they meet their turnaround time? Things like that. So those are the key things that I would look for. The biggest thing, though, is making sure that the deliverable works for you. I mean, there's a ton of coding audit vendors out there, so make sure that you're using the one that works best for you and talk to them a little bit about how they approach audits. Do they approach it in that collaborative manner that I mentioned? Or is it more of a, here, you get this is what you get, and we won't do anything outside of that box, which of course there's benefits to that, but that may not work for your organization. So I think that wraps up all the questions. Of course, here is just a quick overview of the services that we offer at the Rybar Group. By all means, feel free to reach out to me or anyone else here if there's anything at all in the whole entire world that we can help you with. And like I promised, here's my contact information. If you come up with questions later, definitely reach out to me, but I appreciate your time and attention this morning.